Hi there, my name is Roger Pillemer and I'm an orthopedic surgeon with a particular interest in impairment assessment. Early on in the series, I discussed a number of physical signs, and what I would like to do in this talk is show a couple of examples of conditions that have been mentioned previously with some accompanying videos, and another couple of signs that we have not discussed before. These then are the signs that we will be discussing. Posterior cruciate ligament laxity. The cruciate ligaments prevent the tibia from moving backwards and forwards on the femur. The anterior cruciate ligament prevents the forward movement, and the posterior cruciate ligament prevents the backward movement. The most common test used for testing the anterior cruciate ligament is the anterior draw test, and for the posterior cruciate ligament, the posterior draw test. That is, with the patient supine and the hip flexed and the knee at 90 degrees, the examiner is able to shift the tibia backwards or forwards on the femur. There are two less commonly known tests which can and should be done one after the other, namely the drop back sign and the quadriceps contraction test. The first is the drop back sign, where if one looks from the side of the knee, one can see that the tibia drops back on the femur as shown here. The line shows the normal position of the tibia in a stable knee. This drop back occurs purely due to gravity. The second test is the quadriceps contraction test, where the examiner stabilizes the distal tibia as shown here, while getting the patient to contract the quadriceps, either by asking the patient to try and straighten the knee, or push against the hand, or try and slide the foot down the bed. When the patient does this, the quadriceps and patellar tendon pull the tibia forward into its normal position. The video will show the drop back position and how, when the patient contracts his quadriceps against resistance, the tibia moves forward into its anatomical position. Push hard against my hand, hard as you can, and relax. Push hard again and relax. Bend it up a little bit more. Push hard against my hand. Push, 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 push. Relax. Here's an interesting question. In the case of anterior cruciate laxity with a positive anterior draw test, does the tibia come forward when one carries out the quadriceps contraction test? If so, what is the mechanism? And if not, why not? Please think about this before I suggest an answer after we have talked about anterior cruciate laxity. Anterior cruciate laxity. In the second talk in this series, I suggested a more sensitive method of testing for anterior cruciate laxity using the anterior draw test with a patient in the seated position and leaning backwards rather than in the standard supine position. And here is the explanation that was given at the time. The anterior draw test is the commonest test used for testing anterior cruciate laxity, although the ligament test is more sensitive. Now, this is something I found by chance. I had a patient in whom I was not really sure whether there was ACL laxity or not. After he was fully clothed, I decided to have another go. So I sat him down, put my shoe on his shoe, and did a sitting draw test. Laxity was now clearly present. Please try this. In the seated position, sit erect and feel the tension in your hamstring tendons. Now lean forward 30 degrees and you can feel that the tension increases. Sit erect and you can feel it loosens. And most importantly, lean back and you can see it loosens even more. So sit right forward, a lot of tension in the hamstrings, more relaxed, even more relaxed. Now, why does this happen? Well, when you're in this position, the only thing stopping you from falling backwards is the contraction of your hip flexors, the psoas tendons. Now, when the psoas tendons contract, the antagonistic muscles, that is the hip extensors, that is the hamstrings, relax. So when the hip flexors contract, the hamstrings relax. Physiology 101. In my opinion then, when one examines the patient in the standard supine position with the hip flexed and the knee at the right angle, no matter how hard you try and get the patient to relax, there is always some residual tone in the hamstrings. The best position then is with the patient seated, leaning slightly backwards to get maximum relaxation of the hamstrings. This is a short video showing a patient with anterior cruciate laxity, tested firstly in the standard supine position and then showing the increased laxity in the seated leaning back position. Okay, try and relax these muscles as much as you can, Can you feel the difference? Lean back, but don't actually lean on the chair. Just relax it. Okay. Just relax. Okay, that's great. With regard to the question then of whether in the case of anterior cruciate laxity with a positive anterior draw sign, does the tibia actually move forward on the femur when carrying out the quadriceps contraction test? The answer is no. In posterior cruciate laxity, when the tibia drops back, the distal part of the patellar tendon is actually curved slightly backwards, so that when the quadriceps contracts, the force will initially tend to straighten the patellar tendon, and then once the tibia is in its normal position, the pull of the quadriceps is now purely in the line of the tibia, with no further tendency to pull the tibia forward, even if the anterior cruciate is absent. Anterior compartment syndrome. The anterior or extensor compartment of the leg is that space that lies between the tibia and the fibula and contains 4 muscles covered by deep fascia. The muscles are the tibialis anterior, which is the main extensor of the foot, extensor hallucis longus, which extends the big toe, extensor digitorum longus, which extends the lateral 4 toes, and peroneus tertius, which helps to extend and evert the foot. The anterior compartment syndrome occurs where there is increased pressure in this unyielding compartment, where one may get necrosis followed by fibrosis of any or all of the muscles in the compartment. This leads to a tenodesis effect, where the muscle is no longer able to passively stretch and acts as though it were a rope. So the classical sign in a patient with chronic anterior compartment syndrome with fibrosis of extensor hallucis longus is that when the foot is plantar flexed, either actively or passively, the big toe will extend. This is well shown in the following video. Here we go. Up like so, Matt. Just let it go. Okay, let it go down. Up. Down. In a future talk, I will discuss the use and occurrence of tenodesis and the tenodesis effect, which is so widespread in musculoskeletal medicine. Supraclavicular nerve injury. This lesion was discussed in detail in the 9th talk in the series, and for more detail of the anatomy and sensory distribution of the supraclavicular nerve, please refer back to this talk. In my opinion, injuries to this nerve are not as uncommon as suggested, but are actually fairly common, and is simply because it is not being tested for. The only way to make the diagnosis initially is to test for sensory loss in the distribution of the supraclavicular nerve. Once again, ask yourself this question: when did you last test for sensory loss in the distribution of the supraclavicular nerve? This slide shows the sensory loss in the distribution of the supraclavicular nerve. Very often, percussion of the nerve as it enters the posterior triangle causes considerable discomfort as well as paresthesias in the affected area, that is, a positive Tinel sign. The next video is of a lady whom I saw recently who had fallen backwards onto her outstretched hand and arm with her shoulder in an extended position. She shows the classical sensory loss and a positive Tinel sign. She had had injections in her neck and radiofrequency neurotomies, as well as having had injections in her shoulder. Fortunately, to date, she had not come to surgery. Okay, Mary, you feel this one?
Yes.
Sharp all over?
Yeah.
If this is 10 out of 10, tell me what happens this side. Here?
No.
Here? Tell me when you start to feel.
There.
Okay? Tell me when you start to feel.
There.
Come back this way. Tell me when you start to feel.
There.
Okay? So if this side is 10 out of 10, how much is this one?
No,
Can't feel it, Tom. Okay. Now, what happens if I tap over here?
Yeah.
What happens?
Electricity
Goes from there down to there.
Yeah.
And they're very painful.
Yeah.
Right?
It's like
Okay. Once again, thank you for your attention, and I hope that you will join me for the next presentation. And until then, Salani Gashli.